Hello, I'm Dr. Azaz from medicovisual.com, and in today's visual lecture I will briefly talk about metabolic alkalosis. Now, as we have discussed previously time and again, that the term metabolic is truly speaking a misnomer. Not a misnomer, but I think a better term should be non-respiratory. Non-respiratory alkalosis here. The reason is because that in respiratory alkalosis, there is the problem related with PCO2. Basically, the PCO2, the CO2, which is the acidic gas, this acidic gas is low. So if PCO2 is low, that is the respiratory alkalosis. And this problem is due to the something wrong with the respiratory system, right? So the primary cause lies within the respiratory system, but any other cause which is non-respiratory, any other cause that is non-respiratory is going to cause the non-respiratory, I mean, truly speaking, metabolic alkalosis. The standard term is metabolic alkalosis. The non-respiratory alkalosis, as I say, is a pedagogical term to make you understand the concept of it. So I hope you got the idea that this is not a problem with PCO2. The primary problem, of course, PCO2 will change. We will see what happens with it. But the primary cause of the alkalosis lies with the bicarbonate ion. And bicarbonate, as you know, it's the alkali reserve. So to cause the alkalosis, the alkali reserve should increase or decrease. Of course, the alkali reserve should increase, not decrease. It should increase. So, in metabolic alkalosis, the bicarbonate level is high. So, how bicarbonate level can rise? But before that, please understand that basically in any situation wherever there is alkalosis or base excess, it means that the H positive, truly speaking, the H positive proton is low. So there, that is why the pH is high. You know, pH is equal to negative log of hydrogen ion concentration. So the true problem is that pH is high, and pH is high is because that the proton level, the H positive level in the blood is low. So what is going on? How the decrease in H positive leads to increase in bicarbonate? Well, the first line of defense is the buffer, the pH buffer. So whenever pH increases or decreases, the drastic changes in pH is prevented by the presence of pH buffers in our body. And the most important pH buffer in our blood is the bicarbonate buffer system. How does it work in case of alkalosis? Let's say H positive level is going on drastically low, which will lead to too much rise in pH. So, to prevent the excessive and severe sharp rise in pH, the pH buffer, specifically here we are talking about bicarbonate buffer, but all other buffers act in sync. So what pH buffer will do, that if we talk about bicarbonate buffer, it has two components, the HCO3 and H2CO3. So what happens if H positive is low? If H positive is low, then H2CO3 will release a proton from its own, and this proton will be released in blood like this, you see, and it itself will be converted into bicarbonate ion. So it means that whenever there is a decline in H positive, it will lead to increase in bicarbonate ion. So now what is alkalosis basically? If we talk about the normal pH, we have discussed it in the previous lecture as well. We have a narrow range of pH in our blood that is from 7.35 to 7.45. This is the normal range. Depending upon which textbook you follow, there might be slight differences in the normal pH range, but anyhow, the pH that is beyond 7.45 is the range of alkalosis. Now, what can cause the metabolic alkalosis? What are the causes of metabolic alkalosis? So, we will try to understand it very simply. So, if we talk about causes of metabolic alkalosis, it's very easy to understand that very simply if somehow there is addition of bicarbonate ion. So, for example, NaHCO3, the drug that is often used to treat the stomach ulcer. Not treat, actually it is used in management of peptic ulcer, so as an antacid. So that drug, that antacid, its excessive use can lead to metabolic alkalosis. Or am I wrong about it? Well, actually, truly speaking, in a healthy individual, it is very rare to directly get sustained metabolic alkalosis. Keep that in mind. In a healthy individual, to get a sustained metabolic alkalosis directly from antacid abuse is very, very rare. Why sustained? It may cause a temporary increase in pH, but it is typically very temporary, as I as I told you. Why so? Because our kidneys have remarkable potential to get rid of excess HCO3. So if someone takes HCO3 in, ingest HCO3 in, kidney will quickly get rid of it. So that is why it is usually temporary. To make it permanent, there must be some other problem going on. For example, there may be some problem with kidneys secretion ability of HCO3, some kidney failure, or there may be volume loss, the volume contraction that we will discuss. So this alone causing permanent or long-term metabolic alkalosis is very rare, but still it is mentioned in textbooks, so that is why I mentioned it here. Another temporary cause of metabolic alkalosis could be addition of non-bicarbonate base, addition of non-bicarbonate base, or you can say exogenous bases. And by the way, together these are termed as alkali loading disturbances, right? So addition of exogenous bases, for example, citrate or lactate. Now, how can we add citrate or lactate in the body? Well, actually, in stored blood, the citrate is used as preservative in the stored blood. So, if there is massive blood transfusion done in an individual, that actually leads to excess of citrate in that individual, and that can cause the citrate excess, and citrate being a base can cause the alkalosis. But again, it in normal individual whose kidneys are working nicely, and the kidneys can easily get rid of the extra bicarbonate. So rarely, if ever, it causes the prolonged metabolic alkalosis. And what about the lactate? Have you ever heard of ringer lactate? So ringer lactate is a fluid that is often given in the form of drips in some patients. So that can at least temporarily cause lactate excess. Now, the real common cause of metabolic alkalosis is not this one. The common cause is loss of H positive directly. Loss of H positive. Now, how can H positive be lost? H positive can be lost from GIT or it can be lost from the kidney. Let's see how. From GIT, have you heard that vomiting causes metabolic alkalosis? And I have discussed this previously as well. I will repeat it again that in the stomach, what is happening? So, in the stomach, the CO2 is converted to H2CO3 with the help of carbonic anhydrase enzyme, and then H2CO3 converts to HCO3 negative and H positive. Now this H positive is secreted within the lumen of stomach. Along with that, chloride is also secreted in the lumen of stomach. Now this H positive and Cl negative, the HCl, the hydrochloric acid, it is inside the stomach as stomach acid, and HCO3 negative is it gets back into the blood. Now what happens that this HCO3 might actually increase the alkali reserve in our blood, but it doesn't. Why it typically doesn't? The reason is that when this H positive rich fluid from the stomach it comes into the intestine, it stimulates the intestine to release the pancreatic fluid, and the exogenous part of pancreas it release HCO3 rich fluid, a fluid which is rich in bicarbonate. So that HCO3 is released again in intestine and it neutralizes this the stomach acid here in the intestine. So this HCO3 is again utilized. So net result is zero. H positive was released here, HCO3 released here, got back again got neutralized. So ultimate net result is usually zero. But what happens if this H positive never gets to the intestine? Then this HCO3 will remain in blood, and if it continues there will be buildup of more and more HCO3 negative in blood. And how it happens? Simply because of prolonged and severe vomiting. So H positive and Cl negative will be lost in vomitus. Cl negative will also be lost in vomitus. Now, what is the significance of loss of Cl negative? That is very important. I will explain this thing in a moment. But before that, please keep this in mind that it is important that Cl negative is lost, and loss of Cl negative is something that maintains the metabolic alkalosis for a bit longer. If Cl negative was not lost, then the metabolic alkalosis would have been much temporary, just like these types of the one that is caused by addition of NaHCO3 or citrate or lactate excess. It would have been like that. But the situation in vomiting, the metabolic alkalosis in vomiting is worsened by the loss of chloride ion, and I will explain this why it happens. But before that, let me complete this one. There is loss of H positive from GIT via the vomiting, and then from kidney via the aldosterone excess. And how it happens I will just discuss. And it is not just aldosterone, anything that works like aldosterone. For example, even glucocorticoid have mineralocorticoid activity. What I mean by this, it means that the the steroids that are produced in our body, the glucocorticoids, the cortisol, for example, although it is cortisol, but still it has some activity on the aldosterone receptors. So if there is too much excess of glucocorticoid in our body, it can function like aldosterone on the aldosterone receptors. Similarly, there is a plant called licorice plant that can also mimic the action of aldosterone. So anything that is aldosterone or which mimics the action of aldosterone can lead to the excessive loss of H positive from the kidneys, and we will discuss how it happens. So yeah, this was the basic idea. Now there is another cause of metabolic alkalosis, and this cause is quite unique, that it is not directly or inherently caused by the loss of H positive or gain of HCO3 negative. No, not like that, but it is secondary to some other problem. And this is mainly because of the volume loss, volume contraction, and I will discuss that volume contraction. I will discuss what I mean by this and what is going on here. This is very important topic. And this volume contraction is not going on here, but it also worsens vomiting as well. Interestingly, diarrhea typically causes the metabolic acidosis. We have discussed this in previous lectures. But some textbooks and some literature explicitly mention this phenomena, that in prolonged diarrhea, it is relatively uncommon, but in prolonged and chronic diarrhea and some diseases like ulcerative colitis or Crohn disease, that diarrhea actually can lead to, I think it should have been written there. Okay, let me pick it from here and I will put it there. So prolonged and chronic diarrhea, it can lead to volume contraction, and that can sometimes lead to the metabolic alkalosis instead of metabolic acidosis. Now, we will see these things, specifically the volume contraction, and we will try to understand the aldosterone excess. But before that, please understand what will happen when there is alkalosis, when there is metabolic alkalosis. This is very brief topic and very important concept related with it, so I just wanted to mention it briefly here. So whenever there will be the increase in alkali reserve bicarbonate ion, the respiratory system will come into play. What the lungs will do, and lungs won't do it on their own, they do not have their own brain. Respiratory center in our brain will be stimulated. Well, wrong. It won't be stimulated. It will be inhibited. And it will be inhibited. What happens if it will become inhibited? If it is inhibited, it means the respiration will be low. The respiratory rate and depth of respiration will be low. It means the person will hypoventilate. Why the person will hypoventilate? The person will hypoventilate to increase the PCO2 as a compensation. PCO2 is acidic gas. So it means if HCO3 is rising, so this is HCO3, if it is going on too high, it means it would threaten, rather it is actually causing the alkalosis. It is causing the alkalosis. To counterbalance this, somehow to compensate this, the CO2 level will also rise. And if CO2 level rises, the pH can somewhat compensate it. It may not become normal, right? But somehow it might be compensated, partially at least. So that is the role of respiratory system, and that was the respiratory compensation, that there will be hypoventilation at the lungs level. But there is a problem. Hypoventilation will not just cause the buildup of CO2. there will be another problem. Prolonged hypoventilation will also decrease the PO2, the oxygen level. So hypoxemia may ensue. That is not what we want, and that is not what our brain want. So that is why hypoventilation will be limited. There won't be permanent hypoventilation or very strong and continuous permanent hypoventilation. Otherwise there is risk of developing hypoxemia. So this defense, this compensatory mechanism is not permanent, and it is not very long lived. Now coming to the aldosterone problem and volume contraction and the role of chloride, all these things we will try to understand by a simplified diagram of the nephron. So here is nephron. Now please keep this in mind, it is a complicated topic and it is a physiology rich topic. We will have to go too deep in the renal physiology to understand it properly. So that is why I will refrain from going too much into the physiology. We will try to understand some basic concepts related with it, and I might oversimplify some aspects of it. So please bear this in mind. Don't bash me for oversimplifying it. Now, the problem is that if there is volume contraction, what is the meaning of volume contraction? It means the blood volume is low. Simple as that, nothing complicated. Now, what will happen if the blood volume is low? Number one problem, the very simple level, there is no hormones, nothing involved here, no factors are involved here. First of all, what will happen that if the blood is flowing, blood volume is low, please understand, then there will be low GFR rate. There will be low GFR rate. What is GFR? Glomerulus filtration rate. So there is the blood here. This is the glomerulus. Blood will filter itself and filtrate will come into this Bowman space. So the rate of this filtration is glomerular filtration rate. Now, if the blood volume is low, this fluid that is coming here will be low simply because the pressure of the blood, the hydrostatic pressure of the blood will be physically low. So it means in a very simple terms, you see, it means the fluid that will come here will be low. Now understand that if the fluid that is coming here was very high, let's say if GFR was very high and fluid was rushing here, so if too much fluid was rushing here, the fluid will quickly move here and quickly form the urine. Now what would have happened then, the from the proximal convoluted tubules and other parts of the tubules, there will be less time, to reabsorb different materials. This is the simple basic physics going on here. So it means if there was too much fluid, the bicarbonate that must be reabsorbed, because there is too much fluid here, it would quickly rush through here, it will quickly pass through here. Now imagine this is just like you see the police checkpost. You might have seen in some countries there are police checkposts and they do random snap checking. Now imagine if there is too much rush or and too many people are passing from this police checkpost, let's say. So of course, if there is too much traffic, too much rush, police cannot stop each and everyone and cannot check each and everyone. So there is a risk that some criminal might pass through that checkpost if there is too much rush. But consider the opposite scenario. Let's say it's a night time and very few people are passing. Now here is the similar situation. GFR is low. So GFR is low, it means fluid is passing from here very, very slowly. Fluid is passing very, very slowly. Now here are these policemen. Policemen. What are these policemen? These are the proximal convoluted tubular cells. So because the fluid is passing very, very slow, simply because fluid volume is low. So it means they can quickly check and quickly bring in almost all of the bicarbonate. So it means in volume contraction, simple by the simple physics logic, you can understand that there would be increased reabsorption of bicarbonate. And it is not just physics. I will tell you there are some other factors as well that cause this. There is renin-angiotensin 2 mechanism. So if GFR is low and fluid coming in the kidney is low and hypotension problem might be there, blood pressure might be low, then what will happen that the kidneys will release renin will be converting angiotensinogen to angiotensin 1, then angiotensin 1 will be converted to angiotensin 2. I won't tell you the mechanism here, that will take the lecture to some other dimension, I mean to other path, so I won't tell you that, but please understand that what angiotensin 2 will do, it will have different mechanisms. One of the mechanism is that it has to increase the sodium reabsorption. It has to increase the sodium reabsorption, and while doing so it will also increase the reabsorption of bicarbonate. How? Let me show you. So you know CO2 is converted to H2CO3, then H2CO3 is converted to H positive and HCO3 negative in the proximal convoluted tubule. Now this H positive is released into the tubular lumen. How it is released? You remember when it is released, there is an antiporter involved here, and this antiporter, it actually brings in sodium and a positive here. So sodium is brought in while hydrogen is sent into the tubular lumen, and this transporter is actually stimulated. It is stimulated by angiotensin 2 directly. It stimulates this transporter. So while doing so, it is increasing the secretion of proton. Well, doctor has asked, if protons are being lost, then what will happen? There will be alkalosis. Yeah, it can be directly, but here it is not actually truly the loss of proton that is causing alkalosis. The actual problem at this point here is that this H positive will reabsorb HCO3 negative. So excess HCO3 negative will combine with it to form H2CO3, which with the help of carbonic anhydrase, here also carbonic anhydrase is involved, it will be converted to CO2. CO2 will be brought in and then again converted to HCO3, and H positive HCO3 will be reabsorbed in the blood. So it means by the principles of physics as well as by the angiotensin 2, there will be increased absorption of bicarbonate ion when there is volume contraction. The other thing is that it is not just that. There is another thing, that we have cells here in the late distal convoluted tubule and collecting ducts, and within these cells we have ATPase. Which ATPase? Hydrogen ATPase or proton ATPase, which basically pushes the proton or H positive by utilizing ATP. Now this thing is directly stimulated by aldosterone. It is stimulated by aldosterone. Aldosterone. And aldosterone is itself stimulated by angiotensin 2. So it means angiotensin 2 itself can increase the reabsorption of bicarbonate ion, and it can indirectly increase the loss of proton. It can indirectly increase the loss of proton by stimulating the aldosterone release, right? But why it is trying to increase the loss of proton, the angiotensin 2? Well, actually, the angiotensin 2 is not releasing or not promoting aldosterone to cause the loss of H positive. It is doing so because aldosterone has another important action. So, aldosterone, what it does is that it causes the reabsorption of sodium. Well, actually, there are some cells within the kidney. I think they are principal cells. You can check that. Like many other cells on the basolateral side here, the blood side or interstitial side, they have sodium potassium ATPases. So sodium potassium ATPase, they bring 3 sodium out towards the interstitial side and 2 potassium in within the cell. Now, while doing so, what they are doing is that they are decreasing the sodium level within the cell and increasing the potassium level within the cell. So it means that here is the tubular lumen. So it means here we have some sodium and potassium channels here. Sodium potassium channels here. So it means from there the sodium, what will happen to sodium and what will happen to potassium. So sodium is also here, potassium will also here. Now if these channels are working, these transporter sodium potassium ATPases are working and they are stimulated by aldosterone, then what will happen? What will happen to sodium and what will happen to potassium? Will sodium go in or will potassium go in? Please understand this. The sodium is continuously being pumped out of these cells. It means there will be low sodium level within the cell. So it means concentration gradient is established from the luminal side towards the cellular side. It means sodium will move in and potassium is being maintained high inside the cell. So potassium will move out within the lumen. So potassium will move out, sodium will move in. And as the sodium will move in, a lots of water will rush into the body. So it somehow it tries to correct the contraction, the volume contraction. So that is why aldosterone is important. What it actually is trying to do is that it is trying to fix the volume depletion here by increasing the reabsorption of sodium, and while doing so it is also increasing the loss of potassium loss as well as loss of proton. So basically these are sort of side effects of the aldosterone. So it can cause hypokalemia as well as it can cause alkalosis, and that is why aldosterone excess directly can cause, as I have shown you here, the aldosterone or the substances that mimic the aldosterone, they can directly cause the metabolic alkalosis that we have discussed here. Now, the second thing that I want to teach you here is about the potassium. Now, aldosterone, it causes the metabolic alkalosis by stimulation of this proton pump, and it is worsened. This is the main mechanism, and it is worsened by the development of hypokalemia. How? Let me tell you. Whenever there is hypokalemia within the cell, there would be there okay, let's suppose there is potassium level is low outside the cell. So it means cell will try to somewhat recompensate for this to release potassium out of the cell, and while doing so, to maintain the electrical neutrality, they will also bring the H positive in. So inside the blood, the H positive level will decrease, leading to alkalosis like situation. And this is not just cellular level, even at the kidney level. At the kidney level, in the distal convoluted tubule, we have the transporter, the counter transporter, which brings the potassium in and throws the H positive out. So if hypokalemia is there, it means the kidney will try to bring potassium more and more inside, and while doing so there will be loss of H positive, which would further worsen the metabolic alkalosis. So that's how aldosterone causes the metabolic alkalosis, and aldosterone itself is stimulated by angiotensin 2, and angiotensin 2 itself is stimulated by volume contraction or volume depletion. It means volume depletion would worsen the metabolic alkalosis, or it can even directly cause the metabolic alkalosis, as I have described here in case of the prolonged and chronic diarrhea. That was about the volume contraction and about the aldosterone excess. Now, as I've told you, that the vomiting is further worsened by chloride loss, and it is not just chloride loss. If there is severe and prolonged vomiting, there would be also loss of potassium. There might be hypokalemia, and as I've told you, hypokalemia worsens the metabolic alkalosis. On top of that, severe and prolonged vomiting will also lead to volume depletion or volume contraction. That can also worsen the metabolic alkalosis. But what is the real role of chloride loss here? Now, chloride loss can worsen metabolic alkalosis. How? The thing is that in the collecting tubules and collecting duct of the nephron, let me draw a simple diagram here. Here we have anion exchangers. So anion exchangers, what they do is that they exchange bicarbonate with chloride. It means they can push the bicarbonate into the tubular lumen. They can push the bicarbonate in the tubular lumen, and to do so, they have to bring the chloride in. They have to bring the chloride in. Now, if the chloride level is low in the blood, it means less chloride is going to come in the tubular fluid. There will be less chloride in the tubular fluid. So it means, can a significant amount of excess bicarbonate be secreted by the kidneys? The answer is no. So it means, to effectively get rid of bicarbonate, the kidney needs a good supply of chloride ion. And if chloride ions are low, the kidney cannot effectively get rid of bicarbonate excess, further worsening the metabolic alkalosis. So that is why in vomiting or in any other disease, when there is loss of chloride on top of loss of proton, when there is loss of chloride as well, that would definitely worsen the metabolic alkalosis. And in such cases, a simple treatment is giving the sodium chloride infusion. How sodium chloride infusion? Have you heard of normal saline? So if normal saline is infused, patient situation improves a lot. That is why it is called chloride responsive metabolic alkalosis, or it is also called saline responsive metabolic alkalosis. That is important clinical point. These channels, by the way, they are named on a scientist, and they are called pendrins. And pendrins are basically anion exchanger. These are not just the bicarbonate and chloride anion exchanger. There are such pendrin proteins in the thyroid gland as well, where they exchange the chloride with iodine. Both are basically anion, so these are anion exchangers. And before I conclude the lecture, a few important words regarding related with the diuretics, and they also come in this category: the volume contraction, diuretics. And diuretics are the drugs that are given in some diseases like the heart failure. So chronic heart failure, they decrease the blood volume. And while doing so, some of the diuretics, especially the two types, that are the loop diuretic and the thiazide diuretic. What they do is that they also cause metabolic alkalosis. Two important exception here, please keep this in mind, and I will explain why. That carbonic anhydrase inhibitor, they are also a class of diuretic, but they do not cause the metabolic alkalosis. An important class of diuretic, that is also spironolactone or potassium sparing diuretic, they also typically do not cause metabolic alkalosis. To understand why they do not cause that, we will first understand how the loop diuretics and thiazide diuretic cause the metabolic alkalosis. Well, it's very simple and it has to do with the volume contraction. So if I draw a simple nephron again, so here we have actually in the ascending limb of loop of Henle, we have a transporter, and this transporter actually brings sodium. It brings sodium. It also brings potassium in, and it also bring two chloride ions inside. So sodium, potassium, and two chloride ions. Simply because if it is blocked, let's say a common example is furosemide. So if furosemide acts here and it blocks this transporter, then what will happen? Then sodium will be lost in urine, potassium will be lost in urine, and chloride will be lost in urine. Just looking at this, you can understand that loss of sodium will lead to volume contraction. Loss of sodium as well as chloride will lead to volume contraction, and loss of potassium will lead to hypokalemia. And as we have discussed, all these factors actually worsen the and even cause the metabolic alkalosis. We have seen these mechanisms. And similarly, there is the thiazide diuretic which acts here, and they block the reabsorption of sodium as well as chloride, and while doing so again they cause the volume contraction, and we have discussed how volume contraction leads to metabolic alkalosis. Now the question arises that why the carbonic anhydrase inhibitor do not cause the metabolic alkalosis usually. The reason is that this transporter, okay, let's try to understand what it is doing. So again I will discuss that from CO2 H2CO3 forms, and this process requires carbonic anhydrase. H2CO3, of course water is also required here. Now H2CO3 will form H positive and HCO3 negative. Now H positive will be secreted in the tubular lumen, and while doing so sodium will be brought in. Now this H positive, again it will combine with HCO3 negative to form H2CO3, and again it would be acted upon by carbonic anhydrase to form the CO2. CO2 will be brought in, it will just come in, it can diffuse in, and HCO3 negative will be reabsorbed. It means carbonic anhydrase is causing the reabsorption of HCO3 as well as it is causing the reabsorption of sodium. So it means if we block this carbonic anhydrase, there will be decreased reabsorption of sodium, and along with that also there will be decreased reabsorption of bicarbonate. It means more bicarbonate will be lost in urine. If more bicarbonate will be lost in urine, it means the bicarbonate level will actually decrease in blood. The bicarbonate level will actually decrease. So it is more prone to cause the metabolic acidosis rather than alkalosis by increasing the loss of bicarbonate. That is why in the metabolic acidosis, especially in high altitude sickness, carbonic anhydrase inhibitors are given as a treatment. So they do not cause the metabolic alkalosis, rather they can actually cause the metabolic acidosis, although they are still causing the volume contraction, but it is not as much pronounced as especially in case of the loop diuretic, right? Now, a few words about spironolactone. I will not go into its detail, but the point is that it is potassium sparing. It means it is less likely to cause hypokalemia. It does not cause hypokalemia. It might even cause hyperkalemia. So it means hyperkalemia increases the risk of metabolic acidosis rather than alkalosis. So that is why it is mainly the loop diuretic and thiazide diuretic that can cause the metabolic alkalosis. So this is the important point. Regarding the diagnosis of metabolic alkalosis, we have discussed the diagnosis of pH, simple pH disorders, and the idea is very similar. Again, first we will look at the pH level. pH would be definitely high. And along with pH high, when you look at the factor that is causing the high pH, you will realize that it is the increased HCO3 negative level. Of course, there could be the PCO2. If PCO2 level is low, that can also cause increased pH. But because it is not a respiratory cause, it is the cause which is non-respiratory, so there will be increased bicarbonate level. So increased bicarbonate level, along with that there will be increased pH, and this is the hallmark of simple metabolic alkalosis. And to compensate this, PCO2 level will not be low, actually it will be high. If PCO2 level is low, it means that there is mixed disorder, mixed pH disorder. So we will discuss mixed pH disorder in some other lecture, but here we are discussing about the simple metabolic alkalosis, and this was about the simple metabolic alkalosis. I hope you learned something from this video. Thank you so much for watching this video.